All right.
You for keeping me on.
Welcome back, everybody. Another fun question and answer session. For those of you who know me, welcome back, or who have been here, welcome back. For those of you who don't, and I don't know how many new people we get each time. I don't know if we keep track of how many new people we get each time, but if we got any new people coming, welcome to the party. I'm Dr. Leichliter. I am a so-called movement disorder specialist at Allegheny Health Network, sitting here in my office at Allegheny General Hospital. Basically, this is a question and answer session where you send in questions and I answer them to the best of my abilities. We got a whole bunch that I already have in my email, so I'll start with those ones. But as usual, before I like to give a couple of just oversight things to keep everybody on the same page. So this is a general question and answer session. It's not really a great place for specific care. So sending me a message that says, hey, I'm on this and this, and I have this, what do you think I should do next? That sounds like a great question for your neurologist. If it's me, well, send it to me in a different forum. If it's not me, send it to your doctor and they can kind of figure out what the best plan is. So this is more of a general type of question thing. The other thing I like to say is everything you hear is my opinion. Everything I tell you is going to be my opinion. I like to think that my opinions are based on as much medical fact as I can find or as exist, as up to date as I can be. But sometimes there's no evidence or information for the questions that you ask, in which case I will probably make it up. If I do completely make stuff up, I usually tell you I'm making stuff up, and we'll go from there. But again, take everything I say as just my opinion. All doctors, all neurologists, all movement disorders have different opinions. So you may hear something from me and then you go somewhere else and they give you a different opinion. Well, that's why it's an opinion. Throw your questions in the chat box. I will start with the emails that came in first, and then I'll go to the chat box and I will answer as many as I can in as much time as I can do. All right. Let me go back to my emails here. Here we go. The first one. Do I ever prescribe orally inhaled levodopa, or do I have an opinion on it? Well, if you know me, you know I have an opinion on everything. Apparently, it was promoted by the Embrasure rep at a recent country club event, I guess. Yes, I do prescribe it. And yes, I have an opinion. It's okay. And so at the end of the day, sorry, I keep looking over here. I moved my pictures. It's a good rescue medicine. And so there's a few different rescue medicines. And what I mean by a rescue medicine is there's a few medicines that tend to work quickly and be short lasting. And they're particularly useful for rescuing you. So if you have an unpredictable off time, and I know a lot of people always ask about the difference between on and off, and that's a whole different question in and of itself, because not everybody experiences on and off, but a lot of patients do. And so what they feel is when their medicines kick in, they feel good. And then as they wear off, they don't feel so good until their next pill, and the same thing. Some people's off times are not predictable, or sometimes the medicine doesn't kick in very well, and so using these other medicines like Embrasure, which is inhaled levodopa, is a way to get unstuck or out of an off time. Some people use it first thing in the morning when they want to get going a little bit quicker because the pills take a little bit longer to kick in. Some people try it and don't like it. Some people like it. It's kind of like every other new medicine that comes out. It's a trial and error process where I have patients that really like it and really do well with it. And then I have patients who try it, don't like it, and never take it again. It is an inhaler. So if you have breathing problems, it could be tricky. It does make people cough or have some, I don't want to say swallowing dysfunction, but at least a cough and some bad taste. But a lot of people tolerate it just fine, and it does seem to help. But that's kind of my opinion on it. There's other ones. There's Kinmobi, which is a thin film. There's Apikin, which is an injection. So there are other rescue medicines, but that's kind of the long and short about the inhaled levodopa.
Okay.
The second question was interesting. So have I ever heard of the nanotechnology towel patch? And I don't know if it was the person who sent this question in or if it was somebody else, but somebody else did have me look it up. I hadn't heard of it until fairly recently, but I did look it up. And the long story short is this is basically a private company patch where they've designed these different types of patches that you wear that are supposed to be good for neurodegenerative conditions. They have a lot of things on their website written about multiple sclerosis. There's some written about Parkinson's disease, mood, things like that. I was trying to sort through their studies or their research that they had on their website, but it's kind of hard to piece through. Not all of it showed up online. I tried doing it for my work computer. Some of it gets blocked. Welcome to my world at Allegheny. And so it was a little bit hard to get some of the research that they had done. And I don't think any of it was really high quality, i.e. double-blind, randomized controlled trials that we typically think about in medications, which they're probably not going to do. I didn't see anything potentially dangerous or harmful to it. The videos that they show are fairly, impressive. They show people walking before and after the patch, and it does seem to help. But again, it's one of those things that I would have to see. I would have to get my hands on. I would have to have some experience with it. And then the other issue with it is it's expensive. So they have the costs on their website, and it's anywhere from hundreds of dollars per month to a couple $1,000s a month. And again, for something that's not all that tried and true, as far as I can tell, that seems like a bit expensive. Again, I don't tell people they can't use over-the-counter stuff, supplements, other things like that.
Pages and things.
Particularly if,
again, now it's real small.
If you guys want to mute yourselves, that would be helpful.
I can't make it bigger to read the questions and things.
Or Christine, you're in charge of muting people.
I have one person that I cannot mute, and that is Melody Herring.
Huh.
And everyone else appears to be muted. So
seems like a weird IT thing, but okay.
Exactly. I've never had it before.
So I do get a lot of questions about supplements, over-the-counter things, and my general rule is
why are they trying to get you?
Is that as long as there's some science to back it up, or there's some research behind it, and as long as it's not dangerous, meaning it's not toxic, you're not going to put yourself in the hospital, you're not going to hurt yourself, and as long as it's not putting you in the poorhouse, I don't want you to spend all your money on supplements thinking that it's going to be the savior. Then I'm fine. If you want to try it, be my guest. I'm always looking for people to bring things back like that to me, to say, hey, I tried this, it worked. No, it didn't. That's the best way for me to find out more information. Could I discuss the treatment of dystonia with Botox injections? Now normally dystonia is it's a standalone thing. So the majority of Botox injections that I do for dystonia are things like cervical dystonia, which is a completely different disease. But there are things that are dystonia like in Parkinson's disease. So a lot of people get dystonic posturing, i.e. they can get cramping or clawing of their hand. They can get curling of their toes, or their foot goes down or turns in when they walk. Sometimes it's related to medications, meaning it's an off dystonia. Sometimes it's a peak dose dystonia, which is when the pills kick in. That's when you get these things. Sometimes it's not related to medicine at all. The two conditions can go hand in hand. And dystonia purely means abnormal muscle contractions leading to fixed or twisting postures. And so dystonia is really just a description of a movement. It's not actually a formal diagnosis. And it's a muscle cramping or contracting problem. And so when you get fisted like this, or you get your toe curling, it's a muscle contracting problem. And it's different than the stiffness or rigidity or the cogwheeling that people with Parkinson's disease get. They're a little bit different. When you have the dystonia, or the dystonic posturing and the muscle contracting, then Botox is actually a decent choice. So Botox, most people know Botox as a cosmetics thing, but actually they stole it from us. And we stole it from ophthalmology, I think. It weakens muscles. That's what it does. If you give enough Botox or botulinum toxin, it paralyzes muscles. And so you can imagine, if you had a muscle contracting problem and I weaken or paralyze those muscles, then that may relieve the problem. And that's where we use Botox. So if I have somebody who has bad toe curling, or their foot is turning in, I can weaken the muscles in the calf or the leg to try to prevent that from happening. Or if I have somebody who comes in like this, almost like a spasticity or a post-stroke or an MS patient, although sometimes my Parkinsonism patients too, you can loosen these muscles up by injecting them sometimes. And that's where Botox plays a role. Botox weakens muscles. And if you have a really stiff or contracted muscle, you can relieve that with Botox injections. I don't do it a lot for Parkinsonism or Parkinson's patients. In fact, the most common injections that I do for Parkinson's disease are actually for drooling, which I'm actually not entirely sure the mechanism of action of how it works when I inject the salivary glands, but it does. but that's where I usually use it for dystonia. Again, it is a first-line treatment for cervical dystonia or focal dystonia, and it is something I come to in my Parkinson's patients if they do have that problem. Since the duration of Cinemet is about 4 hours, and most people are on a 3 times a day or 4 times a day schedule, they're uncovered during much of their sleep time overnight. Since sleep disturbance is often a prominent part of Parkinson's disease, is it ever reasonable to take a dose in early morning hours if sleep is a problem? Could it be chewed for more rapid action? The short answer is kind of yes to all of the above. So again, there's no real rules with the medicines that we do. And you're right. One of the biggest problems with all the medicines that we have in Parkinson's disease is that they're fairly short lasting. They're not really that good long lasting medicines. The new Pro patches, one, there is a controlled release Mirapex and Requip. Ritari tried to answer that, and there's a Cinemet CR, but none of them are really good like once a day or twice a day medicines. They don't last 12, 24 hours. If you get 4 or 6 hours out of a dose of medicine, you're doing pretty good. And so you're right. A lot of people go to bed at 10, they wake up at 8, that's 10 hours. Or if you go to bed at 8 or 12 hours, or if you're taking your last pill at dinner time and your first pill at breakfast time, you're going a long time without taking any medicine. Now, the good part about sleep is you're not burning up a lot of dopamine. So most people perhaps don't need as much medicine while they're sleeping, although a lot of people do. And a lot of my patients wake up a ton during the middle of the night. I have plenty of patients that take medicine when they wake up during the middle of the night. Now, I usually don't tell people you should wake up to take a pill, but since I have a lot of people who already wake up to go to the bathroom or because they're stiff or whatever, and they take medicine, so be it. And that can cover people during the night. I try in those situations for patients who do have trouble during the night or they wake up not feeling very good, I maybe switch the nighttime dose to the last dose before you go to bed to something longer lasting, like a Cinemet CR, Ritari, something like that. And sometimes that works. But yeah, I mean, the short answer, coming back to the Ambrosia question, that's why some people do take it in the morning to try to get started a little bit quicker. I do have patients who try to take medicine. Maybe they get up at 6, but they don't get out of bed until 8. They take their pill when they get up at 6, and then by the time they're moving at 8, they feel a little bit better. I don't know that chewing the regular carbidopa levodopa really speeds up the absorption or the effect of it. I've had people tell me both ways. Parcopa is an oral dissolving carbidopa levodopa, which I tend to use in people who want to chew it up or want it to dissolve or try to get it to disperse a little bit quicker. But even then, I'm not entirely sure. But the short answer is you could always try it and see what happens. And then I got a question about a new treatment for Parkinson's, and they weren't really sure what it was. They thought maybe it was sonar, and I'm interpreting that as ultrasound. And so I wonder if you're talking about the ultrasound ablation or the MRI guided high frequency ultrasound treatment. And so there was actually 2 processes that were being worked on through ultrasound. So one was a high frequency ultrasound ablation, which is basically through MRI guidance, we can heat your brain up with ultrasound waves and burn a small hole in your brain. And we learned a long time ago that if you put a hole in somebody's brain in a certain location, you can stop them from shaking. It's approved for essential tremor, which is what I've had patients go get it done for. And it's also approved for tremor predominant Parkinsonism, which I have not had people go get done, only because my opinion, this is my opinion, is that essential tremor makes so much more sense. Essential tremor is predominantly a tremor. They don't really have other symptoms. Parkinson's disease comes with a tremor, but it also comes with a whole host of other things that I don't think it really takes care of. And you can only get away with doing one side, at least currently. And so it's not my favorite choice from a Parkinson's disease standpoint or a Parkinsonism standpoint. It's not a bad choice from an essential tremor standpoint, which I've only sent a handful of people for this type of treatment. It's fairly new, and we don't do it in Pittsburgh. The closest one is West Virginia University, which of course, obviously today we don't like them. And then Cleveland Clinic also, I'm just kidding. I like WVU. Dr. Murray runs their program down there. She's very nice. It's just today's the backyard brawl. For those of you who don't know, I went to Pitt for undergrad, so I cheer for them. The other thing that was being looked at a couple of years ago was using ultrasound to open up the blood-brain barrier. And this was really being looked at in the dementias, more Alzheimer's disease, to try to get medications and drugs to the brain. So for those of you who don't know, a little bit of an anatomy course, the brain is actually protected. So things have to get through a specific barrier called the blood-brain barrier to get from your stomach or being absorbed through your blood to the brain. Not everything is able to cross that barrier. It's a fairly tight barrier, and it's formed by the cells that line the brain, the spinal cord. And so it's not always easy to get medications from a pill or from an injection to the brain. And so a couple of years ago, they were looking at, could they use ultrasound to weaken the blood-brain barrier so that medications and things would be easier to get to the central nervous system. I haven't heard much about that recently, at least not in terms of treatment strategies. And so that's something else up in the air. Again, I'm guessing you were referring to the high frequency ultrasound ablation, because that is approved for tremor predominant Parkinson's. But I'm a little bit up in the air on that one. Again, I think I need to see more research. I need to see that it's more effective for just the tremor, which is what I know it works for. And so I haven't been eager to explore that route just yet. And then kind of a follow-up, not necessarily for the ablation, but deep brain stimulator question. So I would like the doctor's input on the following. DBS technology is evolving. There is talk of several developments on the horizon: remote programming, closed loop systems, eliminating the leads to the battery, et cetera. So how do we know when is the right time to proceed? And that's a question that's a whole talk in and of itself, because it has no good answer. So the deep brain stimulator, which is a treatment for advanced Parkinson's or early Parkinson's with significant fluctuations. And it is something that we do here at Allegheny, and UPMC does it as well. And so we actually do quite a bit of deep brain stimulator surgery. But who's the right person? That's a good question. And there's no right answer to that question. It's very individualized. So we know that surgery works well for some things and less well for others. So it's a good tremor medicine treatment. It's a good stiffness treatment. It helps maybe some with movement in general, but maybe it's not very good for walking and balance. It's not very good for memory. It's not very good for speech problems. And so we do have to pick and choose which symptoms we're trying to target or who is the right candidate. It's brain surgery. And I don't want to be the bearer of bad news for you guys, but Parkinsonism is an aging population problem. I would never tell anybody they're old. But they're not exactly spring chickens either. And brain surgery becomes a big issue the more medical problems you accumulate, which you also tend to accumulate as you get older. So you have to be somebody who can tolerate a brain surgery. They have to drill holes into your head. They have to put wires into your brain. They have to hook you up to generators. It's not I always say that if there was such a thing as mild brain surgery, this would be it. But we all know there's no such thing as mild brain surgery. We like people to have a good response to medicines, because we know that surgery works for a lot of the same things that medicines work for. And so if you have a good response to medicine, perhaps you would have a good response to surgery. And so the ideal patient is a relatively young, healthy person with tremor predominant Parkinson's who had good response to medicines, but maybe had side effects to the medicines or fluctuations on the medicines, or maybe we had to increase the medicines and they had problems. That's the ideal person. Now, the ideal person doesn't come to my office all that often, believe it or not. And so these are all things that we have to consider. And yes, there are improvements every year from a deep brain stimulator machinery standpoint. So for a long time, there really wasn't a whole lot of movement in the DBS frontier. But now that we have several companies working on this, they're all competing to be better than the other one. And so they're all trying to improve their product and get to, the lion's share of the market. And there's been long-term talks for trying to make, a all intracranial, meaning no generator DBS. There's been a lot of work on trying to make a self-programming or a learning or a kind of a DBS that could not only measure certain frequencies and things that are going around it, but also react to it without the need of you programming it or us programming it or hitting buttons or anything like that. And probably someday we're going to get there, but nobody really knows when that's going to happen. I'm not sure what on the horizon means. That could be next week. That could be 10 years from now. And they're not really eager to tell me that information. And so I wouldn't be hesitant to send somebody for surgery or for a surgery evaluation, because I think there's a better product coming up in the near future. If you're a good candidate for surgery now, and it makes sense for you now, you go now. I say, hey, let's get you to the surgeons. Let's get the ball rolling, so on and so forth. If you're not a good candidate, or if you're maybe not ready for it, then we wait. I don't think necessarily that the potential for better product or better technology would make me hesitate to send somebody for surgery now. What we've learned actually with a lot of them is, we've been able to do hybrid things where we'll have a Medtronic lead and then a Boston Scientific generator, or vice versa. And so we know that there is some variability. So if a better product comes down the road, we'll probably be able to adapt what we're doing now to kind of accomplish those better technologies. But again, that's kind of my thought on that question, which I thought was a really interesting question. A couple more here in my email, then I'll get to the chat box. I thought this was an interesting question too. Is it possible that a fall that did not cause any obvious injuries could worsen Parkinson's symptoms, such as internal tremor? Yeah, I mean, it can. Just because you don't have any outward injury, bruising, breaking, bleeding, so on and so forth, doesn't mean you didn't do anything to the brain. And even if nothing showed up on, say, CT scan or MRI, again, they're good tests, but they're not perfect. They don't show you cellular structure. They don't show you connections. They don't show you synapses. They purely show you gross structure. And so, yeah, you could definitely cause damage or have increased problems, even though there's no obvious damage or problem. Again, falls are dangerous on multiple levels. And so this is why it's always the thing that I try to avoid the most. And they do cause increased symptoms. They can, let's say you have, we'll use the number 10 just as an idea, 10 neurons that create dopamine now, and you take off one of them from a fall. You might not see that on a picture, but you sure might feel it when it comes time for your symptoms. And so the short answer to that question is yes. And question number 2 was, do symptoms such as freezing of gait ever just go away? Well, I can't say that I've ever seen somebody where they just magically go away. Sometimes they're able to be treated, although again, freezing of gait is a really hard problem to fix. So freezing of gait is the term we will use for people who get stuck. So they're walking and either they can't move, or they stand up and they can't initiate a step, or mid-walk, or if they stop or turn, or if they end up in narrow areas, they can't pick their foot up, or they can't initiate the next step. Sometimes it's short and they just have to kind of pause, wait, and they can get going again. Sometimes it's much longer and they actually have to queue, or they get stuck and they have to wait until they can get started again. That's what we're talking about in terms of freezing of gait. And it's not something that responds all that well to more dopamine medicine, although sometimes it does, and we certainly try. But the short answer is no, I don't know that I've ever seen it just magically go away. I have treated it, and sometimes we get it doing a little bit better, but oftentimes it doesn't respond to treatment either. The best thing for it is probably physical therapy. So a physical therapist can work on cueing. They can work on how do you try to not get stuck, or if you do get stuck, how do you get unstuck, and different techniques to try to keep you safer. That's probably what I've had the best success with. Sorry. All right, now I'll go to the chat box. So what clinical trials do I recommend? Any? That's the short answer. We always need people and patients to participate in clinical trials. Again, this is how we advance the field. This is how we get more information. This is how we learn new things. This is how we discover new things. This is how we revise things that we used to think were true that now we don't think are true. This is how we progress the field. And really the short answer is whatever one you makes sense for you. So they all have different stipulations, different criteria that you have to meet to be a good candidate for. And then it works better if it's something that you're interested in. If it's an exercise trial, but you hate it, or if it's a stationary bike trial and you hate a stationary bike, that's probably not a great trial for you. If it's a heavy duty medication trial or it's a surgical intervention trial and your symptoms are fairly minimal, probably not the best choice. And so it's whatever trial makes the most sense for you. And again, the Michael J. Fox Foundation probably has the best website that really lists a lot of the trials that are ongoing and who's enrolling. I'm currently only in one trial and I'm not enrolling for it. That already closed. I'm not sure what Dr. Bazer's doing. I'm not sure what they have over at UPMC, but they usually do some trials over there. And so there's usually trials going on kind of everywhere. The Sparks 3 trial, I think they're doing over there, which is an exercise trial. You just have to find them, find what makes sense for you, and then, figure out if it makes sense to participate. Swallowing difficulties are a little bit challenging. And again, similar to what I just mentioned, the best place to start for swallowing difficulties is speech therapy. So the way I like to think about it is kind of midline things. So when I say midline things, I'm talking about like vision, speech and swallowing, posture, gait. So kind of things that you imagine running right up the middle of you are really hard to treat with medicines. These kind of things don't respond to medications the way that a tremor does, or stiffness does, or just movement in general does. And swallowing is one of the problems that I've had problems treating with more medicine. The best place to start is really speech therapy. They can see if there's a structural problem. They can do a modified barium swallow, which is where you eat this barium containing food, and they can, through x-ray, watch it go down start to finish and show if it gets stuck anywhere. They can also do trials where they give you different consistencies, such as water, honey, nectar, food, all kinds of different consistencies, and see how you do. And they can also give you exercises to do. They can do electric stim. They can do things to try to help you swallowing. And so speech therapy is probably the best choice. Again, if you've done that, or if that hasn't worked, more medicine would be the next option. But again, in my experience, that's not a great solution. How long until rivastigmine shows it's working? Well, that's a good question. And rivastigmine is tough because it depends on what you're using it for. So I use rivastigmine, which is an Alzheimer's disease drug, for a lot of things. I use it for memory problems, although again, it's questionable efficacy. I use it in walking balance problems, although again, it's questionable. But I use it for problems that don't really have easy or good solutions. And so I use it for problems that if there's any drugs out there that show any type of benefit, or if I've ever had success with them, I'll try them. And rivastigmine is one of those. Exelon is the other name. It depends. Some people feel like it works right away. Some people feel like it never works. I say usually give a medicine 4 weeks, 6 weeks, see if it does anything, and then go from there. And the dosage can be adjusted much like every other medicine. Everything I'm saying about rivastigmine really applies to just about every medicine that we try. It's always trial and error. You do have to give them a little bit of a chance to see if they work. But I would say if something's not doing anything by 4 or 6 weeks, then we should either up the dose if you're tolerating it, try something different if you're not. I'm assuming that means can Cinnamate, can Carbidopa, Levodopa cure the feeling of imbalance completely? I mean, it can. There are patients that exist where Carbidopa, Levodopa takes away their symptoms completely, where it has such an impact that they feel normal. Now, I obviously have a lot of patients where that doesn't happen, and everything in between. And so the short answer is, can it? Yeah. Do I expect it to? No. So I am never expecting complete resolution of symptoms when I'm treating. I'm hoping for it. It's kind of like hope for the best, but prepare for the worst. Art of war, I think, probably. I hope that it does, but my expectation is usually, does it make it a little bit better? Does it make it more tolerable? Does it keep you, again, when we're talking about walking in balance, does it prevent some falls, or does it prevent all falls, but maybe you still need to use a cane or a walker? Again, if it makes you better completely, fantastic. But if it takes you from falling every day to falling a couple of times per month, that's also pretty good. If it takes you from falling with a walker to now being able to use a cane, but still having to be careful, that's still pretty good. And so if it does anything useful, then we're heading in the right direction. Do I have patients where it takes away their symptoms completely? Yes. Is that what I expect? No. Does Parkinson's disease have an impact on mental health? Absolutely. So statistically, according to reports, anxiety and depression come hand in hand with Parkinson's disease 50% of the time. In my experience, it is much higher than that. I would say that most, if not even venturing on all, at some point in time have some sort of mental health problem. Anxiety, depression, apathy, loss of motivation. You could even, group sleep problems in there, insomnia. These all, have impacts on mental health. And so I would say mental health is a huge component of Parkinson's disease. I feel like it's probably underreported and understudied. And so this is kind of a general comment to everybody. Don't be afraid to talk about your mental health when you go see your doctor, when you go see your PCP, when you go see your neurologist, when you go see your movement disorder specialist, because it turns out mental health actually has a very, very big impact on quality of life. And so it should never be ignored. And don't be upset or surprised if somebody, such as myself, tells you you should go see a psychiatrist, or you need a psychologist, or you need a therapist. Just like I send a lot of urinary problems to urology, I send a whole lot of anxiety and depression to psychiatry. This doesn't mean that you're crazy, which is what everybody thinks when I tell them that they should go see a psychiatrist. It means you should go to the person who specializes in the problems that you have. If you have a sleep problem, I send you to a sleep specialist. Same thing. If you have anxiety and depression, PCPs try, but I don't want to, no offense to any PCPs if they're on the line, no offense to other neurologists if you're on the line. I don't take offense. We are not the best at treating anxiety, depression, apathy, mental health problems. This is what a psychiatrist specializes in. And so the short answer is yes. Parkinson's disease and mental health problems go hand in hand, and they feed off of each other completely. And at the end of the day, it shouldn't be ignored. It has a huge impact on quality of life. And so if you can impact it in a good way, you can impact quality of life in a good way. And don't be surprised or upset if we refer you to somebody who really does specialize in that type of problem. It really is worth it to go to them. They do a much better job. And not just a psychiatrist, but I find particular benefit for a psychologist. Parkinson's disease is tough. I know. I'm going out on a limb on that one. I'm telling you things that are shocking. Parkinson's disease is tough. It comes with difficulties, frustrations, anger, issues that really impact your mental health. It is hard to deal with. It's a slow, long-term condition, chronic condition that really does make things difficult. And working with somebody who can help you deal with that. And I don't mean deal with that and me just saying, oh, just suck it up, buttercup, because that's stupid. But in somebody who can help you work through it, who can figure out where you're having difficulties, who can give you coping mechanisms to try to work through these things, it really helps people. And so again, I don't want to say I get upset or angry when I suggest that somebody goes to a psychiatrist or psychologist and they say, I don't want to do that, or why do I have to go to them? I don't get mad, but it's because they're better at dealing with these things. And these things are really, really important for day-to-day life, for quality of life, for handling everyday living with the disease. That's not easy to do. You guys do a tremendous job of it, but sometimes it is hard, and sometimes it becomes too hard. Again, don't look at it as, oh, he thinks I'm crazy or he thinks I'm nuts, that's why I have to go see a psychiatrist. That's not the case at all. These are the best people to work on mental health issues, and mental health plays a big role in quality of life. Can I comment on that article next month? Yes. Well, let me see if I've read it. What was that from? May? So I've probably read it, but yes, I don't remember it offhand. So let me look at it for next month, and I'll talk about it. Because again, DBS and Parkinson, what you're going to see moving forward is more use of technology, more use of invasive things, more use of wearable devices. Technology is not going anywhere. In fact, it's only going to be more and more of how we take care of patients, I mean, look at what we're doing right now. I mean, 10 years ago, can you imagine having a Zoom meeting of I don't know how many people are on the line, 81 people to have this conversation? I mean, it wasn't even a thing, right? And now we do it every month. And so technology, including things like surgical interventions, more invasive technologies, are going to be more and more prevalent and more common. And so, yeah, let me look at that article, which I'm sure I've read, but let me look at it anyway, and we'll talk about it next month. Am I familiar with motor-free visual perception problem? And this a progressive worsening problem. I mean, not specifically, but if I had to put together what I think it means, I'm assuming it means that, you know, your motor symptoms are being impacted by your visual perception of how the world is around you, or how your vision input affects not just your vision, but also your movement ability. And I don't know if I'm going to answer your question correctly later or not, but I'll do my best. But at the end of the day, there is a lot that is disrupted from basically input of visual information getting to your brain and then affecting how you move or navigate the world around you. And no, it doesn't work perfectly in Parkinson's disease. A lot of patients complain of vision changes, double vision, blurry vision, which again, I've talked about before, and are always very hard symptoms to try to work on. But there's also a processing problem in Parkinson's disease. So visual input, sensory input, auditory input is not always perceived correctly. And then if it is perceived correctly, it's not always dealt with correctly. So again, the brain is, I know I'm going out on a limb on this one too, the brain is complicated. And there's a lot of moving parts that all work simultaneously that we have a hard time understanding how a change here affects a change here. And so we're not all that great to try and tease together all how the pathways combine, how they all interact, how they all work together, and how people process information, deal with information, and react to information. But the long and short of it is, in Parkinson's disease, in any type of brain condition, there can be problems anywhere along the pathway, forwards and backwards. And so I'm assuming that's what you mean by that type of visual perception problem. Again, it's a hard thing to fix. Any type of vision or connection problem is a hard thing to fix. You know, we are not very good at rewiring the brain. So if there's a problem between input of sensory information to output of motor activity or some sort of response, we're not really good at correcting that. These types of things are things that don't respond as well to medications, and you'll hear me talk about that a lot. When we think about the actual non-motor symptoms of Parkinson's disease, i.e. everything, just about everything except the tremor, stiffness, slowness of movement, and balance problems, just about everything else are much more difficult to treat and respond with medications. And this is one of them. And so again, I think that's what you're referring to, but the short answer is all of these problems that are really input or connection problems are really hard to work on and really hard to fix. I like this. You guys are giving me lots of articles to read. You know, I try to stay up to date, and I get 2 different journals that show up on my desk all the time. One of which is the Movement Disorder Journal, which was where the last one was from. That's how I'm pretty sure I've read it, because I am caught up to date in terms of the August issue that's sitting on my desk right beside me. But I get the journal from the American Academy of Neurology as well. And so this is one way that I get a lot of information. You also get a lot of information from talking to other people, from going to meetings, things like that. So there's a lot of different ways that kind of research or information gets to me. But anytime patients bring me articles or things to read, I take those seriously, because again, just because I read a couple different journals and I go to meetings and I talk to other people does not mean that I am getting all the information that is out there. Drug reps also used to be a good source of information, particularly about medications and indications for certain medications, but now they're not even allowed in my office due to COVID, although I think that's probably getting expanded. And so, yeah, anytime you guys come across something that's interesting or that seems to have merit or that we should look into and think about, send it to me. I'll take a look at it. No problem. How do we titrate Cinemet? I think that's the question that's there. And that, again, you talk to 10 of us, you'll get 10 different opinions. This is me, my opinion. Usually what I do, if I'm starting somebody on Carbidopa, Levodopa, I'll start with a half a pill twice a day for a week, go up to a whole pill twice a day for a week, and then a whole pill 3 times a day. If that's not enough, maybe I'll go up to 4 times per day, or if 3 times a day is easier, I'll increase it up to 1.5 pills, maybe 2 pills, and then I'll start layering in other medicines. Everything I just said in the last 10 seconds is not written in stone. That is not a study. That is not a evidence-based. That's just how I was taught and how I learned. And you'd be surprised how much of what you learn or what you're taught you carry over into your own practice. I've seen people start with 1 pill a day for 3 days, and 2 pill a day for 3 days, and 3 pills. I've had people just start at 3 pills a day. I like to kind of gradually increase and gradually decrease. That's just my rule of thumb. But there's no right or wrong answer. I have some people that we start slower. If they have other medical problems, or if I think they're a little bit frail, then maybe I'll start with the 10-100, or I'll start with just twice a day and see how they do. I mean, there's no actual rules. And likewise, the same thing is true in the reverse order. So if, let's say, we do something like deep brain stimulator surgery, or we do something, how do we backtrack? That's not written down either. There's actually no good studies that really suggest this is the best way to add medicine. This is the best way to take away medicine. There's not much written about this is the best order to try medicines outside of, there was a journal article that came out last year in the American Academy of Neurology journal that suggested that carbidopa levodopa is generally the best drug to start with. But even that had some caveats to it. And so there's not a lot of rules to how we use medications. It's a lot of subjective decision making. So when I'm talking to you in the clinic or in the office, and I'm listening and I'm watching, which I always do, by the way, I start watching you as soon as I walk in the door. That's when my examination starts. But when I'm trying to figure out what the heck are we going to do with you, and I'm trying to figure out, okay, we need more medicine, and these are the symptoms that we're going to try to fix or work on, and this is how we're going to try to do it. That's when I'm trying to make up, okay, what's the right medicine? What's the right amount? What's the right way to add it on? What's the right way to increase it? What are we trying to accomplish? That's really what I'm thinking about in the office when we're talking. As you're telling me what the problems are and I'm watching you and seeing how it goes, I'm constantly thinking about, okay, what do we need to work on? What's the biggest problem? What am I hearing is the most problematic issue that we need to address? And then I go back, okay, what are the medicines that I have, or what do I have at my disposal or my arsenal to try to work on it? None of that's written in stone. None of that is, here is what you do, boom, 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 boom. None of this is a timeline of this is how everybody gets treated. It's all very, very individualized. And so that's kind of my general titration for somebody that I'm just starting on medicines. But half the time I make that up anyway. What features of presentation, tremor, no tremor, no balance problems, better respond to medications, and are there red flags for more rapid disability? Yes, yes, and yes. So the symptoms, this is sort of my opinion, but also proven in studies, the symptoms that respond the best tend to be tremor, they tend to be stiffness, they tend to be slowness of movement. The symptoms that respond the least tend to be balance problems, a lot of rigidity, particularly truncal rigidity, speech problems, vision problems, all the non-motor symptoms. And so, yes, some symptoms do respond better to medicine. Some symptoms do respond better to deep brain stimulator surgery. Some symptoms don't respond very well to medicine. Some symptoms don't respond very well to surgery. And these are all things that I keep in mind. The general rule of thumb is that tremors and stiffness and slowness of movement tend to be the ones that things like carbidopa, pramipexole, these medicines tend to work the best for. And then the non-motor symptoms, so anxiety, depression, lack of motivation, apathy, balance problems, sleep problems, mood problems, vision problems, speech problems, these tend to be things that the medicines are less effective for. Not to say that I don't have a patient who I put on carbidopa, levodopa, and his balance was fixed. I've seen it. Not to say that I don't have a patient where I put them on Cinemet and their speech was better. I've seen it. I get that there are some people that do respond to some of these, and not to say that I haven't had a patient that I put on Cinemet and their tremor doesn't get better and their stiffness doesn't get better. I have seen all of those things. These are just kind of general rules of thumb in terms of what I would say is most common or most consistent in terms of symptom and treatment strategies. The red flags for rapid disability are if you have a lot of walking and balance problems or falls early, that's a red flag for me. Not to say that you can't be stable and you can't do well long term, but these are, again, general rules of thumb. If you have a lot of swallowing problems, or if you have a lot of memory problems, particularly early on in the course, again, these are things that I keep in the back of my mind. I say, wait a second, what's going on here? Things that I traditionally or typically don't see until later in the course of disease, if they happen early on, they bother me. And so those are kind of some of the things that I keep in the back of my mind. Anything that would suggest that there's a Parkinson's plus condition or an atypical Parkinsonism, such as lack of response to medicine, early hallucinations or hallucinations before I put you on medicine. Again, a lot of falls. All of these things are things that, again, don't necessarily tell me, oh, this isn't going to go well, but they're things that I at least have to keep in the back of my mind to, hey, we need to keep an eye on this. We need to see how this goes. And so, yeah, there's a whole bunch of red flags and things that I'm keeping an eye out for. Those are just some of them. And hopefully that answered your question. Can I please provide the link to the research of my work of the advantages of directional DBS? So I'm assuming you're referring to, I was in a trial for the directional DBS for Boston Scientific, and it's published in the Neurology Lancet, I think. I can find it for you, and I could give it to Casey or somebody to post. I'd have to go look it up, but that was really the study that helped get Boston Scientific in the market. That study's been closed, and so that paper's already been written. They're still reviewing a lot of the directional stuff, and they're still kind of teasing through. This is what you'll find happens in trials. So you're in a trial, there's a kind of beginning, middle, end, and then after the study, you'll see the publication. But even after the publication or after the study is done, people are still going back through subsections of patients, subtypes of things. They're still reviewing the work, and a lot of the directional lead work is still being looked at and still being reviewed. But I can get you that paper if you're interested. So I've been reading about the correlation between Parkinson's disease and the gut-brain axis. What is my position on the prescription medication called rifaximin? Or I can't remember the other name for it, but there's another name for it. The short answer is I haven't seen enough data to suggest that rifaximin should be prescribed in Parkinson's disease. Again, when I'm recommending a medication for Parkinson's disease, if I'm recommending a medicine, then I need to see data. I need to see studies. I need to see trials. I need to see something that suggests, scientifically that it makes sense and that it's going to work. There is a lot written about the gut-brain axis. There's a lot written about people thinking that Parkinson's disease starts in the intestinal tract and works its way up to the brain. There's a lot of evidence to suggest that there is a lot of dopaminergic or dopamine-producing neurons in the gut. There's a lot written about that connection. What we haven't been able to do, or what I haven't seen thoroughly, is that we can impact it. Meaning I haven't seen enough evidence to suggest that impacting the gut does anything for Parkinson's disease. Now, obviously, there are definitely GI symptoms that come with Parkinson's disease. And so a lot of constipation, a lot of gastric emptying problems, a lot of motility issues. Those are all treated with GI medications or things of that nature. But I haven't actually seen or at least been convinced that impacting the gut flora, the microbiota, things that like probiotics, things of that nature. I haven't seen enough evidence for that they impact the progression or Parkinson's disease enough for me to say, yep, you should do it. Now, again, and rifaximin, it does come with its own set of side effects. And so I wait until I hear more about things. I see more trials on things. I am a slow adopter of a lot of things. I'm a neurologist. I am not very aggressive. I'm as passive as they come. I really need to see good evidence before I say, yeah, that's a great idea. Let's do it. Now, that's different than, hey, I'm going to try rivastigmine because I want to see if it works on your walking imbalance. If there's really no good treatment options, then I'll use kind of questionable studies or questionable things to see if it works. But I really like to see or prefer to see good trials that really suggest a benefit before I really endorse something. And so that would be my opinion on that. I have no doubt there's a strong connection between the gut and the brain. And I have no doubt that that plays some sort of role in Parkinson's disease. It's fairly well shown and it's fairly well written about. What we haven't been able to do is really impact it. And that's what we're still waiting for. I'm still waiting for how we use that information, how we use the information that there is a connection there to our advantage to help patients. That's what I'm still waiting for. Oh, okay. That's from Casey. I was like, oh, that's useful information. Have I had any patients that have developed their own processes of reducing their symptoms and have succeeded? Like Howard Schiffke. I don't know. I mean, I have patients that do all kinds of stuff. My patients are well read. They read a lot. They research a lot. They bring me articles. They bring me things to review and talk about. They try things on their own with or without my blessing. So the short answer to your first question is, yeah, I've had a lot of patients take their health care and take their Parkinson's disease care in their own hands. I can't think of anybody who came back to me, again, such as that claim where he reversed all of his symptoms and eliminated all of his medications. I have never once seen that, is also the short answer to your question. Believe me, if somebody comes to me and they said, I did this and I was cured, I would be telling you guys first and foremost, I would say, let's try this. Again, I've seen this work. I've seen somebody be fixed. We need to do this. I've never seen it. I've never had somebody, and this is true for every supplement. And believe me, I have patients that take every supplement, every over-the-counter thing, everything you can imagine. I've had patients do, and I've never had somebody come back and say it fixed me. So I don't know what he did. I'll have to go kind of sort through what his claim was. I don't know what he did that cured himself. But I have never had a patient come back and tell me that. I'm not against trying those things. Again, I'm not against trying outside of the box things. Again, I always use the example of I've been a certifier of medical marijuana since it was approved. Do I think medical marijuana fixes Parkinson's disease? Of course not. Or you guys would all be on it. Do I think it has a role? Sure it does. I think it helps calm down anxiety. I think it helps with sleep. I think it helps with pain. Again, is it a cure? No. But I'm not against using outside of the box things, probably more so than a lot of other people. But I also take everything with a grain of salt. I'm also very skeptical of people when they say stuff like that. I'm very non-believing. I've been told I'm a little bit pessimistic once or twice. I like to call it realistic, call it whatever you want. But I don't believe things unless I see them for myself, unless I've had success with it, unless I get a chance to do it in my patients, or if somebody comes to me physically standing in front of me and says, look, I'm better. There's a lot of stuff online. There's a lot of videos, and I just don't believe any of it until I see it up person. That's just my own opinion. Again, I'll look a little bit closer into that and see what exactly he did, or what he's touting, or I guess what his claim to fame is. I'm not sure what it is, but I'll look into it. But again, anytime somebody tells me that they've cured it or they've fixed it, I almost stop listening, because again, if that was the case, I'm pretty sure everybody would be doing it. Just learned from inside. Okay, that was from Casey. So apparently the focused ultrasound is approved for the other Parkinson's features. Again, I'm a slow adopter. This is the high frequency ultrasound ablation. And so I really have to see evidence, maybe even try it once or twice and have somebody come back and tell me it's a good thing or a good response before I become an adopter or user of it. Seen MIT work diagnosing Parkinson's disease and progression by a breathing monitor and artificial intelligence. I'm telling you, artificial intelligence is something very interesting. So again, I've been skewed by science fiction movies again in terms of what I view artificial intelligence as, but realistically, artificial intelligence in the healthcare world is something you guys are going to see and hear a lot more. From things that listen to you in the exam room and create a note, to information sorting, you're going to see the use of artificial intelligence in the not so distant future. So case in point, I don't know if you guys have ever seen wearable devices. So I used to actually, one of the companies actually let me try one, and it actually gives you a whole bunch of information about tremor, stiffness, slowness, movement, things like that. And so you can imagine, let's say you wear a wrist device and it measures heart rate, blood pressure, tremor, movement, sleep. Imagine how much, let's say you wear that for just a week. You know how much information that is? You know how much data that is? Do you know how many data points that creates? Do you know how long that would take somebody like this guy to go through and figure out what it all means? Do you know who wouldn't really be that excited about having to go through all of that data and try to figure out what it means? This guy. And so that's where we're going to have machine learning, artificial intelligence, sorting through data, because that's coming. Wearable devices, technology that you guys have at home, even if it's just in a smartphone, or if it's in a wrist device, or some other type of accelerometer or gyroscope, these things are coming. I've seen kind of prototypes. I've seen some used in real life action, especially with video technology, where if I don't have a patient directly in front of me, I can still get a lot of information about how they're doing based on this information. Again, I know not everybody likes technology, and my patients are probably some of the people that like technology the least. It's coming. And technology in the medical field is not only not going anywhere, it's only going to be more. Just anticipate that, know that. Am I excited about it? A little bit, not really, but I have to do it too. And so artificial intelligence is going to be one of those things that really is used because of all the data that's going to be coming. You know, at some point in the near future, we're going to have access to so much information that there's no way we're going to be able to sort through it or really digest it in any usable form quickly. And so you're going to see things like that. And I agree, it is all cool. I'm not sure how it's going to work just yet or how these things are going to be effective, but you're going to see more and more of it. What is my position on meditation, Tai Chi? I think it's Qigong, although I have no idea how to actually say stuff like this, and similar modalities as an alternative treatment for Parkinson's disease. I think they're great ideas. I was a little bit skeptical of things for like acupuncture, you know, massage, Reiki, Tai Chi, but I've had success with them. I've had patients come back and say, hey, I had acupuncture and I felt better. You know, Tai Chi's been relatively proven as a treatment strategy. And so all of these things, we hear a lot about mindfulness, meditation. You know, there's a lot of evidence. There's some evidence out there that it is actually beneficial for not just Parkinson's disease, but just about everybody. But there is some evidence in these things in Parkinson's disease as well. They're hard things to quantify. They're hard things to publish a randomized controlled trial about, but there is some scientific data to support it as literature. And the good part is about them is it's not another medicine. I give out a lot of medicines. If you're my patients, you're probably on a lot of medicine. I prescribe a ton of medicine. I don't like prescribing a ton of medicine. I would prefer not giving you another pill. I would prefer not increasing your carbidopa, levodopa. If there's a way we can get you doing better without having to give you more medicine, I am all for it. And so at the end of the day, I think they're all helpful. Do I think they're going to fix things? No. But do I think they help? Yes. Again, I don't want to call it a mantra, but something that I always think about is my goal is I'm pretty sure every one of your goals, which is to keep you guys functioning as well as possible, as long as possible, on as little medicine as possible. That's always my goal going into a room. That's generally what I gather is your goal as well. And so all of these things are helpful, and I think they're all worth doing or considering. Again, it's similar to exercise. Exercise is my absolute favorite thing to talk about. If you're my patient, there's no way you've come talk to me in the office or have seen me and we did not discuss exercise. That's never happened. It never will happen. Exercise is my absolute favorite thing to talk about because it's really beneficial. And again, any of these things, and this includes to some extent things like chiropractic manipulation, acupuncture, Reiki, other things that you can think of. I'm not against any of it. Do I think any of these things are fixes? No, I don't think there's a fix. But do I think they help? Yes. And if they allow us to use less medicine, I'm all for it. Does an abnormal DAT scan ever improve with dopa therapy? So dopamine therapy can skew a DAT scan, meaning it can give you a false negative result. But the short answer is no, because it's not actually fixing the underlying problem. So replacement dopamine or levodopa or any of the medicines that we use are not fixing the underlying problem, which is loss of the cells, loss of the transporter. They are correcting the symptoms. So they're bypassing the underlying deficiency and they're treating the symptoms. And so the realistic answer is no, it shouldn't ever correct an abnormal DAT scan, although it can artificially correct what you see on a picture. And that's why they usually tell you to hold your medicine for so long and whatever they do. Check out how Qigong exercises. Okay, I will get to that. And yes, the Parkinson's Foundation offers Tai Chi virtually. Thank you, Casey. And with that, I'm only 3 minutes over time, so that's actually not too bad. And so I think I answered all the questions, so I'll stop there. Again, I'll let Casey on in a second, but the short answer is we'll keep doing it as long as you guys keep having questions. I thought these were all great questions. And guess what? If you have a question, most likely somebody else in the audience has the same question. So don't be afraid to ask it, even if it's already been asked. And as long as you guys have questions, I'll keep doing this. If we ever get to the point where not a single question comes in, that's when I'll stop. But I don't think that's going to happen anytime soon. One caveat, and Casey will reiterate this, one caveat about next month's talk is I'm going to move it a little bit earlier in the day to, what did I say, 4:15, Casey?
4:15.
I have to give
October
another
6th.
talk. So October 6th is the first Thursday of October. That'll be the next time I do this. It will be earlier because I have to give another talk that evening and I have to drive an hour or so to get there. That's why I'm moving it. I didn't want to cancel it. I still want to do it, but we'll just move it earlier, but this will all come through Casey. All right. It's all yours, Casey.
Oh, wow. Well, thank you. I know you're busy. You're very dedicated. We really appreciate it. And just wanted to mention that this is recorded. Go to our YouTube channel. And then we have Step Forward. We just got the shirt. Step Forward on Saturday, September 17th. So you get this really nice maroon shirt. It's very nice. And it's our largest fundraiser. So check us out. Go to our website, Step Forward, September 17th. And thank you, everyone, for attending and asking great questions. I'm always learning. I know we all are.
Go cheer on Pitt.
Yes, cheer on Pitt and keep
And
the
Penn
hope.
State if you want to. They
Yeah,
play too.
that's true.
I'm not against that.
Okay.
All right. Thanks, guys. We'll see you next time.
Okay, bye, everybody. Thank you.